Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. I am Dr. Abdullah Al-Harbi, a neonatal fellow at the National Guard Hospital in Riyadh, and I will be your moderator for today's session. I'm really thrilled to welcome all of you to Neonatal Fellow Lecture Series presented by the Saudi Neonatology Society. Today, we have the privilege of hearing from a distinguished leader in the fields of neonatal neurology and neonatal neurocritical care. It is my honor to introduce my esteemed teacher and aspiring mentor, Prof. Khorshid Mohammad. So Dr. Khorshid, he's a staff neonatologist at Alberta Health Services, a clinical professor of pediatric at the Cummings School of Medicine, University of Calgary, and the chief of education committee and a founding board member of Neonatal Brain Society, and he's a neonatology site lead for Alberta Children's Hospital in Canada. Dr. Khorshid graduated from University of Damascus and Arab League with master and specialty degrees in pediatrics. He completed the neonatal fellowship at the University of Calgary, neonatal neurology at the University of British Columbia, and targeted neonatal echo at Universities of British Columbia and Calgary. In 2014, Dr. Khorshid established the Neonatal Neurocritical Care Program, and he's a founding member of the sonographic clinic assessment of the newborn scan program. So Dr. Khorshid's main area of interest are innovation in education and the quality improvement. He established a neonatal brain monitoring simulation lab, including cranial ultrasonographic phantoms and simulators, brain MRI simulators, EEG simulators, and neurological exam using virtual realities. He developed several teaching modules in neonatal neurology and organized several conferences, workshops, and courses in neonatal neuromonitoring. Dr. Khorshid's quality improvement work led to significant reduction in mortality and brain injury in extremely preterm and term infants suffering from asphyxia and seizure. His area of research interests are education, brain perfusion, monitoring, and quality improvement neuroprotection strategies. So today, Prof. Khorshid will share his innovative approach and guide us through the steps to prevent IVH in premature infants. His knowledge and experience are invaluable as we strive to improve our neonatal care. If you have any question, please post them in the question and answer box, and they will be addressed after the presentation. So let us give a warm welcome to Prof. Khorshid. So the mic is yours, Prof. Khorshid.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks, Dr. Abdullah, for the kind introduction. It's a real pleasure and honor to present to you guys about IVH prevention. And if you notice, the title is different from the title we proposed in the poster. And the poster title was saying guided steps to prevent IVH. And I intentionally kept this one to make the point that I have presented this talk in several meetings and among several groups. And the more I'm thinking about it, I am more convinced that this works better as a workshop. I did go ahead and run it as a workshop last week in Sao Paulo, Brazil. And I think it works much, much better. And I wanted to let you know that there will be a workshop, inshallah, in Taif in October on the IVH prevention, a small group discussion. So today, what I would do in the presentation, though, is to give you the very key point in preventing IVH for anybody who wants to start a bundle in their unit. They really need to pay attention or consider this key steps in preventing IVH. They are the absolute must, because if we included everything in the bundle, we will go way beyond 1 hour. I will be happy to share all the resources that we have if you are interested to put together your own IVH prevention bundle. So I start with a question. In Saudi, you don't see this for sure, but in Calgary in winter, it snows most of the days and most of the month. In the morning when I wake up, my driveway, this is where I pull my car, is covered with snow. And because I take my kids to the school, I have to make 3 trips before I go to my work. And sometimes I don't have time to shovel the snow. I convince myself that I will go back and forth and I will only make one track. It will be still easy to shovel the snow. And as you can see on the left, it's a delusion. Despite my best intention, there are many, many tracks that I have made back and forth through my 3 trips before going to work, which makes the shoveling of the snow very challenging after that. The other picture is, you probably will know and you can relate to it. For a long time, we thought that we can identify the location of electrons through their orbits around the nucleus. And then as the theory improved, now we know that we cannot be sure for 100% the exact location of the electron. Rather, we can know with a certain confidence that the electron will be within this cloud, and we came up with the cloud theory. So these 2 pictures, there will be a slide in my presentation related to these pictures, and I will ask you at the end of the presentation which slide in my presentation was related to these 2 pictures, and we'll see who can pick that up. Okay, the way I organized this presentation here, I wanted to present the evidence first that this works, and then walk you through the key steps which for each system. I picked 1 or 2 interventions for each system's hemodynamic, respiratory, infection, etc. Of course, we can expand on those when we put together our own bundle. But the reason why I put first the evidence, because there was no evidence when we started this, and it is very, very hard to convince a group that is such a simple intervention will make this big impact. As intensivists, we used to look into big, expensive piece of equipment or things that require big grants or drugs to make such a big impact. Everything we have done here was without any grant, without any funding. It was by the will of the people. And the first time I remember when I presented to one of the visiting professor here to Calgary, I was young, enthusiastic. This was in 2013. I went over the bundle and he let me finish. He was listening patiently. And after I was done, he told me, and I am quoting him, "Are you trying to convince me that by covering the incubators and using pin lights, you will decrease the incidence of IVH?" End quote. And he went on and he said, "We spend millions and millions of dollars to try to decrease this problem and get rid of it, and we are not able until now. There is no way with this simple intervention that cost nothing, you will be able to decrease the IVH." 10 years forward, this is the evidence. This was the first publication that we have done looking at the unborn babies, born less than 29 weeks gestational age, extreme premature babies, born at our level 3 hospital. 3 years before the intervention and 3 years after the intervention, we got more than 600 babies. You can see here, pre-intervention, we had 301, and after the intervention, we had 364 extreme premature babies. And the bundle, we were able to significantly decrease the use of inotropes. We were able to significantly decrease the use of normal saline boluses. The delayed cord clamping was part of the bundle, so the uptake of that was significant. The rate of pneumothorax, because of the standardization and protocolization of our ventilation, was decreased significantly. And to our surprise, the use of opioids, this was unintentional. We didn't intend to decrease the use of opioids in this population, but because of the minimal handling and perception that we are not putting this baby through painful stimuli, the team was more comfortable not starting opioids. And guess what? If you don't start babies on opioids in the first 72 hours, the chances of keeping them on sedation is much less. So there was a significant reduction in the use of opioids after the intervention. And then we looked at the rate of mortality. It was reduced by more than 50%, same with the composite of death or severe brain injury, and same with severe brain injury or death or surgical post-hemorrhagic ventricular dilatation. The rate of any IVH also was decreased significantly, but it wasn't by 50%. And here you see after the intervention, there was a sharp reduction in the incidence of IVH. There was a fluctuation was still there, and then eventually the fluctuation also decreased, meaning the new intervention became the standard of care and it was the new norm. We did, as you know, you need to do the multiple regression analysis, controlling for confounding factors, and we also did the interrupted time series analysis to make sure that the change that is being seen is due to the intervention, not because of the change of practice over time and the change in population. Because one of the criticism, especially in the use of inotropes, was that your population has changed and maybe the babies are less sicker, or you are having babies with higher gestational age, etc. So we controlled for all that, and despite that, the intervention still significantly decreased the incidence of severe brain injury or composite of death or severe brain injury. What about outborns? So the criticism continued. It said, sure, these babies are born at the level 3 hospitals. You guys are expert. You get more than 130 babies per year, extreme premature babies who are used. You do all this intervention because your team is so good. What about the babies who are born outside the tertiary center? Well, we looked at those as well, and it was the same trend. We had a significant reduction in all those parameters that I have mentioned with similar analysis, including the interrupted time series analysis. Whether they were outborn or inborn, this bundle has decreased the incidence of severe brain injury or mortality. Now, the ultimate questions remain. And one advice I will make here, if you are doing any QR work, please publish it. Because if you don't publish it, it didn't happen. And any group that published on quality improvement in the reduction of IVH or any neuroprotection intervention, it will help the other groups. Is when we started this, there was always the skepticism. They were always saying, did you publish this? Is there any evidence there? And there was nothing there. And even after we published the short-term outcomes, the question remained, what about the long-term outcome? Good, you decrease the IVH. It's a similar story like prophylactic indomethacin. Prophylactic indomethacin decreased the incidence of severe IVH, but the long-term outcome, there was no difference. I want to make one point here about the long-term outcome and trying to link them with the short-term intervention. It's really hard to link a short-term intervention with a long-term outcome because there are so many factors that come in place. And the question is how long you are willing to wait before losing the significance of the early intervention. Even with the things like cooling, if you look at the long-term outcome, like the hospital, the school age outcome, you'll see that you lose the statistical significance. Nevertheless, we looked at the long-term outcome with the impact of the IVH bundle, and there was a significant reduction in the incidence of severe or significant neurodevelopmental impairment, and there was a significant clinical reduction in the cerebral palsy because the numbers were low anyway, pre and post. There was no statistical significance, but clinically there was a difference. Okay, so that's that. What about comparing ourselves with the rest of the country? And that was another question. Maybe it's good in your center. How do you know that you are doing better compared to the rest of the country? Maybe the practice in Canada is improving. This is a funnel plot comparing all level 3 centers in Canada. These dots are the tertiary centers in Canada. And if you are below the midline, that means the odds of having the severe brain injury is below 1. If you are above the midline, that's bad. And we used to be in the middle of the pack. And then after the intervention, we were the lowest center in Canada, and we maintained that for 3 years. And then the evidence started to come. Other groups have shown that the implementation of the bundle does decrease the incidence of brain injury in premature infants. And also this works in the resource-limited countries. This is part of our outreach program where we go and visit other centers. This was a visit to Quito, Ecuador. And this physician is Dr. Hoyos from Bogota, Colombia. She went back and she started the bundle in her center, and she showed that by the by implementation of such bundle, she was able to decrease the incidence of brain injury significantly compared to other centers, and their network is called Epic Latino, and they have a network that's similar to the neonatal network in Canada. But there were at least a couple of publications. They showed there was no difference after the implementation of the bundle. One was Mount Sinai in Canada, and there was another paper from Sunny Jewel Group. And why is that? How can we reconcile this fact that it works in some centers, most of the centers, but it doesn't work in other centers? And the way to solve that is to understand the relationship between the QI and research. There's lots of confusion. People confuse QI and research, and they use them interchangeably where they are not. And the QI, the way I look at it, I call it the art of science. You bring the science and you try to integrate it into your own system, the way that will work for you. The example I will give is the use of prophylactic fluconazole. In centers where you get high incidence of candidemia, it's worth to justify it to decrease the incidence of candidemia from the baseline of 20 or 30%. But if you don't have the candidemia, if your incidence is 5%, there's no point for you to bring such intervention. And it is estimated that for an idea to come from the bench to bedside, it takes about 10 to 15 years, 10 to 15 years for that idea to come to the bedside. So those ideas are very, very precious. We need to use the QI to integrate this idea the best way into our complex system to make sure that give it the best chance to succeed. Otherwise, we will disservice all this work that has been done to bring this idea to the bedside. And an example we have locally, we learned this. We tried to introduce the dexmedetomidine, the dexmedetomidine, that's the Precedex, called the short name for it, the brand name, to our unit. There were publications in pediatric population where it's shown that if you use the dexmed in post-surgical babies, you may decrease the use of opioids. So we brought this idea, and without getting it through the proper QI methodology, we just implemented it after we put the protocol together. And our hope and goal was to decrease the incidence or the burden of post-surgical opioid use. And to our surprise, it was the other way around. The introduction of dexmed significantly increased the use of opioid in our center. And we published this shameful paper to just use ourselves as a cautionary tale for other centers who want to introduce a drug without a proper QI methodology. And then we went back to the drawing board and we started to introduce the dexmed through a proper QI methodology. And only then we were able to decrease the use of opioid by adding the dexmed to the algorithm. And what is the main impact of QI? Why is it different from the research? What does it add to research? Why don't we just stick to research? If there's evidence, if there's meta-analysis of a drug or intervention that works, why all this confusion? Why all this addition? What QI does that research doesn't, it decreases the variability and create consistency in the system. If you look here, after the intervention, there was a reduction in the incidence of composite of death or severe brain injury, but the variability was still there. And eventually the QI decreased the variability. It will never be a flat line because you cannot cleanse and clean the environment that you are living in. Otherwise, it will be similar to any animal study that you are running, or it will be that we are faking or making up the data. But the hope is that this fluctuation will be so small that's really close to the target number that you are targeting. And if you let your guard after you made the change and the QI is not in place as strong, as robust as before, the first thing you will see in the system that changes, not the incidence of your target. For example, here it's not the incidence of IVH. What will come back is variability. And that will be your warning sign that something is going on and your system is falling apart. You need to go back and revamp your bundle to bring back the consistency and decrease the variability. And that's what happened with us, which I will show later, that when we let our guard down and we loosen our implementation of the bundle, the variability of the system came back and the incidence of IVH increased. Okay, so how do we decrease the system variation? Because this is the key in any quality improvement intervention or success. We need to, when we develop our protocol, we need to involve the stakeholders. Those are the leaders for each portion of the bundle, or the operational leaders when you want to implement it in the NICU. We want to look at the process measures, and that's our audits. We look at the variables, the risk factors, or the protective factors. Also, we'll talk about balancing measures. We will talk about the outcome definition. And finally, we'll talk about implementation. But before that, this part is for the person who wants to lead this project. If you are leading, or if you are thinking of leading such project, you need to have these 4 qualities. And that goes back to the story of وَزَادَهُ بَسْطَةً فِي الْعِلْمِ وَالْجِسْمِ. When you are a leader, or you want to be a potential leader, you need capacity. You don't need to have all this when you are starting the project, but you want to have the capacity to develop these qualities while you are working on your project. You need to develop the knowledge, really deep knowledge in the topic that you are targeting. You need to have the burning motivation. You see nightmares of the outcome that you are trying to avoid. And you need to have a credential, authority to make that changes, and you need to have the right character for that. So for me, I was thinking of how can I build capacity for these 4 character or 4 items. And this is my attempt to do that. For you, it will be different because your challenges are different and the way you are thinking is different. But it is important to keep these 4 characters and 4 items in mind when you are leading any quality improvement project at this scale, at very large scale. So the first one was, I wanted to read books about the challenging conversation, because I knew I am the most junior person in the group, and I will face very strong personality, very intellectual people that will make the case against what I am trying to do. So I will read books like Getting to Yes, Difficult Conversation, Crucial Conversation, Nonviolent Conversation, because you will get angry. People will attack you personally, and they will call this bundle as your bundle. And you're faking the data, you are trying to make up this thing. So that anger will prevent you to think clearly through. So you need this kind of techniques to deal with this people. And then the leadership challenge, and the top dogs, and David and Goliath, or the underdogs, and the influencer. And then personally, to keep feeling the drive to 0, I changed my license plate to make it drive IVH to 0. So if every day when I am driving to the work, I feel the drive, I will never forget about the project. It keeps me always alert about the project. And then while I was reading these books, one of the things they mentioned, if you want to make a change, you have to pick a challenge that is very difficult for you, that you have been always looking to doing it, and then try to do this challenge while you are implementing that big scale intervention. And for me, running was the challenge. For you, it might be something different, it might be swimming, it might be reading, it might be developing some kind of software, but you pick up that challenge that you always wanted to do it, but it's very difficult for you. So my goal was to get to half marathon at the end of the 1 year of intervention. I was never a runner before and was able to do that. But the point of this too is, one, to keep yourself always reminded of the project. And the second one is to have this motivation, that flame of burnings going, and never be gone away. And then in the knowledge of QI, I did not have any knowledge of QI when I started this. I picked a mentor who was expert in QI and started reading about it. And authority, I was the most junior person, so I didn't have any authority among my seniors. So I picked 2 mentors who were leaders in this, very senior and leaders in this field, and they were the one who protected me and provided this environment to make sure that the implementation will not remain as ink on the paper, as they say. So now to the interventions themselves. I picked 4 in preparation of the bundle, and then in between, while we are transitioning to the 4 intervention after or during the implementation. I'll go quickly through them, and hopefully we'll have some time for discussion. And as I said, this worked much better as a workshop when we will have a discussion on each one of these items back and forth to make it suitable or modifiable to your own institution. So first is problem identification, and that will be one advice I will make for core people who wants to lead this. You are the leader, you put together your team, you know each one what they are doing, but the first step I would say is to go back and read about the physiology. Because once I started reading about the physiology of brain injury in premature baby, lots of interventions that I was hoping to do, suddenly I realized it might be harmful at such a certain stage when it is protective in another stage. So really we need to go back to physiology and understand what type of brain injury are we trying to protect or prevent. You have 3 types of brain injury. When we started this project, we faced with 3 types. One was the cumulative white matter injury that happens over time. The second was the post-hemorrhagic ventricular dilatation. And the third, the one we decided to go with, is the reperfusion IVH brain injury. When we started this, the first we decided to do actually wasn't IVH. It was the post-hemorrhagic ventricular dilatation. And the plan was for us to go and negotiate with neurosurgery. How can we protocolize and prevent the injury post-hemorrhagic ventricular dilatation? And it became clear that there's lots of work to do there. And by the time we reached to agreement, many IVH will happen. And one is too many. So we didn't have the luxury of time of waiting until we come up with a protocol and agree and do the intervention. There were so many variabilities that we need to address. So we decided as a group, if we can prevent IVH, then our incidence of post-hemorrhagic ventricular dilatation will decrease, and we will have more time to deal with those small numbers of babies that will have post-hemorrhagic ventricular dilatation. And fast forward about 2 years post-intervention, I got a phone call from a neurosurgeon who's telling me it's either this IVH thing is working or your phones are broken because you guys are not calling us anymore for the post-hemorrhagic ventricular dilatation intervention. So prevention is more important than management after the injuries happen. So we went with the reperfusion injury prevention, or the IVH. And here where it becomes important to understand the physiology. I won't be able to go over the whole physiology, but I do want to make the advice and the point that really spend time to understand the physiology. IVH is your enemy, and we need to understand our enemy ins and out to be able to defeat it and prevent it. One of the reasons why premature babies are at risk of germinal matrix hemorrhage is because of the anatomical structure of the venous system and the vascular system. As you know, the medullary veins, they pass through the germinal matrix. So if you have IVH here that didn't pop through the ventricles, the pressure will build up and it will compromise the blood flow that's coming from the veins, will cause venous infarct, and infarction always get followed by hemorrhage. So you get that classic grade 4 hemorrhagic infarct. Similarly, with the vascular system, where you have the arterioles, they end at the germinal matrix level. So if you have ischemia, the first area get affected is the germinal matrix, and ischemia always get followed by reperfusion. So about the outcome measures, which tool will we be using to measure our outcomes? Were we using the MRI or the head ultrasound? I don't need to convince you that because head ultrasound, we can do it at the bedside, we can do it right away, we can do it repeatedly. It really is the way to go for this specific intervention. For MRI, you need to move the baby to the facility. You cannot do it frequently, although you will miss some type of brain injury, but those types are not the one we are targeting. Remember, we are targeting the reperfusion type of injury, not the white matter type of injury, which will be missed by head ultrasound, and you will need MRI for that one. And I want to pause and present this case here to make one point about the head ultrasound. This was a 23 plus 6 weeks at birth and got 1 dose of steroids, the mom, and born at our tertiary center vaginally, was intubated at the delivery room. Cord gas was 7.19. The admission temperature was borderline, got the central lines inserted. This girl had RDS, required surfactant, failed extubation several times, had CO2 fluctuation, and had mixed metabolic and respiratory acidosis, all risk factors for IVH. And sure enough, the report came back as grade 4 IVH on the left, blood in the ventricles, no ventriculomegaly. I just copy paste the report here. And for any of us, without looking at the images, we will approach the family, and talking to them about redirection of care will be very reasonable. 23-week girl, no steroids, still ventilated, had all risk factors of IVH and had grade 4 IVH. And that's what our team did. We approached the family, we talked about palliative care, and the mom kept pushing back on us to the point that our team in the background was labeling this mother as quote unquote difficult mother. But the point I wanted to make here is, if you are using the ultrasound to counsel the families, it's really crucial to look at the images and be descriptive. And the reason why, if you look at these 7 images, you will rightly label them as grade 4 IVH because there is blood inside the parenchyma. But clearly the outcome of this top left one is much better than the one on the bottom right, because this is massive grade 4 IVH as compared to tiny grade 4 IVH. If you don't look at the images and you read the report, you will lump all these 7 together and you will approach the families the same way. However, if we are using the ultrasound as an outcome measure to test our interventions, let's say IVH bundle or any other intervention, it is important to standardize the way we are classifying brain injury. And that will be the second step before your intervention. I would recommend that you sort out before doing any of your IVH prevention bundle interventions. We did these 2 steps backward, but we learned from our mistakes. After we did our intervention, we went back and we thought about the physiology of the disease, and we also went back and we standardized the way we are classifying the preterm brain injury. But my advice will be to do this 2-step upfront. So the variability in the classification of preterm brain injury is a reality. These are centers in Canada, and you see the variability in the incidence of severe brain injury, and these were countries in the INEO networks where you see also there was a variability in the preterm brain injury incidence. And part of this is because of the way we are classifying preterm brain injury, because grade 4 might not be grade 4 for you, and grade 3 might be grade 2 for me, and vice versa. So what we did in Canada, we have put together this task force of neonatologists, neurologists, neonatologists and radiologists and neuroradiologists. And we put together a consensus approach of standardizing the screening and classification of preterm brain injury. We published this in an open journal. You can download it. The app will be there, and all the pictures and the atlas will be there as well for you to use. So now, risk factors versus protective factors. Initially, when we started this project, we only focused on risk factors. And then we drew the root cause analysis. We bundled them into themes or systems like the hemodynamic risk factors, ventilation risk factors, handling outborne infection, PDN, PPHN, or RDS, which will protect or cause the brain injury. And then we built our intervention packaged on these themes. And the rule we followed was the 80-20 rules, that 80% of your outcome happens or because of the 20% of the risk factors. So we targeted those priority big risk factors that leads to higher risk of IVH. But as we were doing that, we discovered that we are overprotecting the babies and we are missing some of the nurturing moments. And that's where one of the things we need to pay attention more to and encourage more. And the one example is encouraging the interaction between the parents and the baby. And the one good news is Only by auditing, without any intervention, you will be able to decrease the incidence of IVH. And that goes back to the fact that we all slow down when we see cops on the road because we are worried that we will get a ticket and we know that somebody is watching us. There was a group in Germany, they published just that. They published that by systematically auditing and the risk of IVH, they were able to decrease the IVH. And that's a very good news for every center that they are trying to decrease the IVH. And we found that as well, that was start to trend down even before the intervention. Now, the fourth step before the intervention itself is approval versus execution. At the stage of developing your bundle, you will need approval, and that approval comes from stakeholders. When we put the hemodynamic portion of the bundle, we went and we approached our hemodynamic group and we got their approval before implementing it. Similarly with the respiratory portion of the bundle, same with the ID and so on. But when it comes to execution or implementation, you need to pick up a group that will guard your intervention by their heart, by their soul, and they will implement it with all their might. And the best group for that we found were nurses. Nurses were guarding the incubator to the point that we got lots of complaints from neonatologists that they will label the bundle with bad names, I won't mention it here, is preventing us from even touching our babies. The nurses are not allowing us to examine our babies. So they are that good. So you need to get buy-in from your nurses, explain the bundle to them through the nurse educators with pod talks at the bedside until they are really convinced that this is good for the baby. And once they are convinced that this is good for the baby, you are in business. They will make sure that your bundle is implemented. And this were our group that we put together for the bundle itself. Now, before moving to the 4 interventions, while you finish your bundle, now you're ready to go, you need to set an ambitious goal. You put your team, you gather your team, that's your moment. We are ready now, the 0 hour is coming. What should we do? We need to put an ambitious goal that will generate lots of discussion and buzz. And for us, we decided, we say we will decrease the incidence of severe brain injury by 50% in a year starting this date. It's important to have a starting date, so you build the motivation. Everybody's looking to that starting date. And by putting the ambitious goal, lots of people came to us, they say, you are setting yourself to failure. 50% is too ambitious, you cannot do it. And that's only fueled us and increased our desire to reach this challenge. We put the dates, launching date was 21st of September 2015. So everybody was looking into that date and was watching the results. And now the intervention itself, as we were studying our risk factors, we spread them, we drew the roadmap, and then we created our mini packages or bundles based on these windows: prenatal neuroprotection bundle, transportation neuroprotection bundle, the golden hour, and the management around the birth, and then the critical window in the first 72 hours of life. The outreach or golden hours, we had our outreach program. We visited every center that's sending babies to us. You can do similarly. I don't know the setup and your institutions. Some you have tertiary center where you get babies from other hospital. I know you in Saudi, they have the live line when they get all the consultations there. So you need to develop a system where you consult these outbound patients, the hospital who get the extreme premature babies and before they get transferred to your institution. So what in our trips, we advocated for in utero transfer, and to our surprise, when we did the analysis initially, we did the analysis for inborns and outborns. When we submitted the papers for inborns and outborns, the reviewers rightly pointed out that outborns are different populations, so you need to publish on inborns and then publish separately on outborn. But the point here, when we did the analysis for the whole cohort, we found that there was a significant reduction in the outborn babies after the intervention, and that was due to the advocate for in utero transfer. And you will be surprised that if you initiate the conversation early that can this mom be transferred, how many times that is possible. Sometimes or often we wait longer than needed until it's too late and the mom has to be transferred at the hospital where it's level 1 or level 2. Of course, we advocated for antenatal steroid, for magnesium sulfate, and magnesium sulfate does not decrease IVH, but it is a neuroprotective agent that can improve the long-term outcome. And of course, we put all this in the outreach program, and we put together a neuroprotection bundle on transportation that deals with some things like vibration, noise, keeping the head in the midline, and etc., and light. And this is just an example of infographic that we have put together. I'm happy to share all this with you guys and walk you through the minutes until you see the target at 60 minutes and what kind of intervention you will be aiming for. The one thing I want to mention about the golden hour is that the 60-minute is not absolute. It's something that you should aim for, but it shouldn't be on the expense of overhandling the baby to achieve this goal. Because the goal of golden hour is really gentle, minimal handling. And if you are losing that goal, even if you reach 40 minutes, 50 minutes, that's not a golden hour. It's probably will be less than gold for sure. Some golden hour for some units will be 90 minutes, some will be 80 minutes, whatever your median is, as long as you are following these steps and interventions that required for the golden hour. And then critical window, we had to come up with the window that is long enough to capture our interventions and risk factors we want to prevent. And at the same time, it should be short enough to prevent the fatigue. If you have a long window intervention, then people will get fatigue and your implementation will become less robust over time. So we came up with this 72 hours window because most of the injury happens in the first 72 hours window. If you can avoid IVH for 72 hours, then the chance of having that injury after 72 hours is much, much less. And we advocated during this window to have the baby in the midline head position, which is this position is completely wrong. And then the question of having the baby prone or having the baby skin to skin with the mother got arise. And the way we got around it, we said, as long as you don't do the complete turning of the head, extreme turning, and trying to have it somehow, somewhat midline, then the skin to skin is encouraged. And if you need to avoid intubation by putting the baby in prone, that's okay as well. Hemodynamic management probably requires a whole complete lecture about it, but this is one of the most important intervention if you want to prevent IVH, and that's the standardization of the way we are approaching the hemodynamic instability in premature infant. And one of the reasons for that, as you know, the brain autoregulation in premature babies is either compromised or it's completely gone, meaning it's pressure passive. The lower the blood pressure, the lower the flow to the brain and vice versa. And also, when we studied the numbers of epithelial progenerator cells, these are the building blocks of vessels. In the cord blood in premature infants, we found that the babies who ended up having IVH, they had significantly lower number of APCs, and there was a dose effect. The worse the IVH, the lower the APC, the meaning that they were prone to ischemia to start with, and ischemia always followed by reperfusion. And we looked at the association between inotropes and the incidence of severe brain injury in premature infant. There was lots of discussion and back and forth about this paper and this concept, which I'll be happy to talk about during discussion. But nevertheless, we found that there was a strong association between brain injury and the use of inotropes. And part of it is our own practice. So what we did, we asked for we encouraged the natural cord clamping or delayed cord clamping. We said no screening with routine cardiac ultrasound anymore. The baby is stable, and we will treat after, for the typo ruling out iatrogenic causes like pneumothorax or hyperventilation, and treat if their clinical manifestation like high lactate trending up, decreased urine output, or prolonged capillary leaflet time. None of these elements, clinical manifestation is perfect. But by only putting those kind of breaks, we were able to decrease the use of inotropes significantly. And we advised that to start with low dose of dopamine of 5 micro and don't increase it unless you wait for the response. If the baby needed treatment clinically, if he has this
low blood pressure and clinical signs, then the cardiac echo become very, very important. You need to guide your intervention based on your finding. Is the heart full? You need inotropes, or it's empty, you need boluses. Is there PPH in? So you better start INO, or is there something else that you need to treat? So it is important if clinically the baby manifested signs of hemodynamic instability is to do cardiac echo to guide your treatment. So I want to show you this just to make the case for delayed cord clamping. This is a primate giving birth.
Here it comes. Here it comes. This is it. That's the head. That's it. It's out. It's out. That's it. She's starting to remove the amniotic sac. Whoa, there we go. Yes, it's... Wow, she's just cleared the baby's airways. He's reacting to his daughter's birth. First sounds. This is amazing. It's incredible.
It's interesting that the base on which we based our current practice of immediate cord clamping was based on the assumption that the cord is dirty. And yet it's taking us so many RCTs and evidence to come back what's common sense in nature. And it always amazes me how people will design studies for something that's common sense. Delayed cord clamping is common sense, physiologically makes sense if when baby breathes, because the lung in utero is collapsed, it doesn't have any or very little blood flow. When it opens up, it's like a sponge. It needs to take that blood from somewhere. If you cut the cord right away, it will take the blood through the PDA from other organs, potentially from the brain, from the gut, from the kidney, putting them at risk of ischemia, and ischemias always get followed by reperfusion. So that's one of the really big interventions that we need to aim for more. And with our intervention, we were able to decrease our inotropes. I did mention that to you, and we published this paper. PDA diagnosis and management, I don't think I can solve it here, but I can tell you my approach to this is certainly not the only approach. We did look at them in our cohort, and we had 258 cases with available echo or TNE. And the bottom line, what we found that if you treat based on echo only, you are probably treating too early. And if you are treating based on clinical only, you're probably treating too late. So there is somewhere in between with the echo versus clinical approach. And there the question of prophylactic endomedicine comes, and this was a study we did in Canada, in all tertiary centers in Canada. Interesting, what we found, there was a 26 weeks cutoff. Below 26 weeks, the incidence of both spontaneous bowel perforation and brain injury was decreased significantly. After 26 weeks, you lose the protective effect of endomethacin, but the incidence of spontaneous brain bowel perforation increases significantly. So we developed what is called targeted prophylactic endomethacin treatment for babies less than 26 weeks gestational age who did not receive any or partial steroids. And the way I treat the PDA, if the baby is extreme premature baby, had RDS, received surfactant, still ventilated at 24 hours of age, I do the echo, and this is the echo. The color code is if the blood moving away from the probe is blue, if it's moving toward the probe, it's red. And you can see there is an alternate between blue and red, meaning this PDA is bidirectional, which that was confirmed on the Doppler. You see the biphasic wave of through the PDA. I treat it when it's mostly left to right, because if it's completely left to right, then I know the brain is at risk of ischemia or stealing phenomenon, and I treat these babies with endomethacin. And this was one recent paper from the Iowa group where they showed that there was, with the targeted approach of PDA treatment in this population, they were able to decrease the incidence of brain injury in these babies. And finally, the respiratory management. What we looked at the CO2 impact of on the IVH, and as you know, CO2 is a potent vasodilator. And to our surprise, it wasn't the hypercapnia, which was bad. It was the metabolic acidosis. And we went back to physiology. Again, the point, we need to go back to physiology whenever there's something doesn't make sense. We read that it's only when the CO2 get converted to hydrogen ion that it can cross the blood-brain barrier. And there was again a dose effect. The worse the metabolic acidosis, the higher the risk of the IVH and the grade of IVH. So you try to avoid the metabolic acidosis, and especially the mixed respiratory and metabolic acidosis. And then it comes the question about intubation, extubation, when to extubate, who to intubate, and when to re-intubate them. And the point here is you have to have a protocol in place, and it has to be clear guidance when to extubate and intubate and re-intubate this baby, because variability is your biggest enemy. And I know we are at 51 minutes, so I will skip through this. What would you do if you, despite this, all your intervention, you end up with grade 4 IVH, or you end up with post-hemorrhagic ventricular dilatation, or you end up with white matter injury? And I wanted to present these two cases to you. These were 25 weeks twins. They had gone through our IVH prevention bundle. They had all the complications that you can imagine in the NICU, during the NICU stay. They had CMV infection, they had PDA ligation, they had BPD, and one of them, the boy, had grade 3 IVH with severe post-hemorrhagic ventricular dilatation, and the girl had grade 4 IVH with porencephalic cyst later on. And this is an example of white matter injury. This is an example of post-hemorrhagic ventricular dilatation. We did lots of work with our nurses. We trained them how to do cranial ultrasound and how to tap the reservoir themselves. And we were able to tap these babies close to 200 taps right now, and with 0 infection. That's because the nurses are more diligent when they do the cleaning and the tapping themselves. And this was published by Linda DeVries group. When they give it to the hand of nurses, the incidence of infection was decreased significantly, and also the chances of doing the tapping on time increased significantly if you give it to the hand of nurses. And for the girls, we have this neuroplasticity intervention, and again, this would take another talk, and it's focused on our 5 senses. What kind of neuroplasticity intervention? When it comes to smell, we give a mom's a fabric tissue, she rub it against her chest, we put it on baby's eyes, and through that they can smell their mother, and also some of the normal flora, the chances of that being transferred to them. Touch, the kangaroo care, the facilitated tugging. Taste, by promoting mother's own milk. Hearing, by the reading program. Singing and talking to the babies by the staff and by their parents themselves, because only family can lift the baby up. So this is the video of that girl that I showed you, and the mother wants to share this with you guys, and this will be my last slide. We're out of it. Mother's own milk, so that see how she satisfies them. And now she starts to walk. That's right. So she had grade 4 IVH, she had porencephalic cyst, she had cerebral palsy. But through putting her in interactive, loving, stimulative environment, and through the dedication of her mother, she defeated her level. She was able to run and walk and be happy interacting with her brother. And that's not all, because this mother, despite being handful with two babies, which you can label having neurodevelopmental disability, she decided to go back and study nursing and become a NICU nurse. And I met her about a month or 2 months ago. She's now a practicing nurse in our unit. So back to my slide, if somebody can write down, what do you think this track related to which slide in my presentation? You can put it in the chat box. I want to thank you all and happy to take questions.
Thank you so much, Prof. Khorshid, really for your outstanding and insightful presentation. And really, we hope it will influence our daily practices as we care for our tiny babies and strive to protect their brains. And just before moving to question and answer, I would like to remind everyone that this presentation, along with our previous ones, has been recorded and will be available on our YouTube channel, Saudi Neonatology Society channel. And I will encourage everyone to subscribe and continue learning with us. And I will post the link in the chat box now. So moving to the question and answer, and Nimri has raised his hand.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
شكرا دكتور عبد الله، شكرا دكتور عدنان، شكرا من الأعماق لهذه الشعلة التي أشعلتها بجمعية طب الأطفال حديث الولادة، زادها إشعاعا ونورا وتوهجا ما شاء الله تبارك الله. دكتور خورشيد، بروف خورشيد محمد، دائما أعتبرني براس لكل الفلوس الموجودين، وهذه فرصة طيبة. زاد هذا التوهج وهذا النور ذلك الحضور ما شاء الله تبارك الله التي وصل قرابة 200. ضربت الرقم القياسي بروف خورشيد، كنت أعتقد أنا ذا فيرست وان، لكن ما شاء الله يكسيد ذا اتندنس باي 200. عندي سؤالين بروف خورشيد لو سمحت لي. واحد you can answer it now، الثاني ممكن delay it at the end of the lectures. الكويشن دائما when you come to implement the bundle, do we need to implement it all ولا we'll take it step by step? We'll start with the daily cord clamping, or maybe we'll start with the golden hours, or we need to go to the nursing. And the second part is who's going to implement that bundle? This is my first question. The second question هو نبراس للفلوس. At the end I need your real advice, sincere advice to our new graduate from the fellowship of neonatal medicine, how they can achieve their career to reach to the neonatal neurology, or what we call a subspecialty الآن neurology، خاصة في طريق النور اللي انت ماشي فيه. زادك الله بهاء، وشكرا من الأعماق لدعمك المتواصل لجمعية طب الأطفال حديث الولادة. شكرا.
بارك الله فيك دكتور نمري. You are our teacher صراحة and a mentor for us, and it means a lot coming from you. To answer your questions, first, the bundle, in my opinion, has to come together. That's why we call it a bundle. Now, while we are preparing the bundle, when you are auditing the risk factors in your own unit, you will find the priorities changes. For us, for example, the use of inotropes was very high, so we made that a priority. The ventilation practice was all over the place in the first 72 hours, so we made that a priority for us. The way we treat infection, so you look for sources of variabilities, and then you put it together and make it part of your bundle approach. Because if you pick one intervention at a time, and you can make the case that none of them has a good evidence that it can prevent IVH. If you look at the midline head position, for example, the last meta-analysis came out, it shows that it doesn't decrease the incidence of IVH. But it's only when we put it as a bundle, and the main result of the bundle is really creating consistency and protocolization of management, and that is what is making the impact, the biggest impact. And the way I was able to sell it to our group is we have consulted these specialty groups, and we agreed on this bundle. It will never be perfect. I can myself now criticize the bundle and tear it apart. But what I'm asking from our group is to live with it for 6 months, and we will promise that we will audit and study this bundle and come back to the group and see if there's anything we can improve to the bundle. That gives them kind of assurance that we are not just implementing and leave it to the air. We are looking at assessing it through the PDSA cycle, and we will come back to the group and report back to them. Who will implement it? I think we need first to find an owner for it, the leader for it, and that leader need to have a strong support from people like yourself, stakeholders, because they will be faced with lots of challenges, and only having the senior mentors that develop the safe environment for them. Example, I remember my mentor was telling me, you go and do whatever you want, and if you face any trouble, blame it on me. I will be your bad person. And that way you feel comfortable to go and explore the areas and do this kind of innovative interventions. My advice to the fellows is from the book. One of the book I mentioned is David and Goliath, and talking about the story of David and Goliath. When I came back here to Calgary, my mandate was to establish the neonatal neurocritical care program. We did not have any program established in place. We didn't even have amplitude integrated EEG. They had to cancel one of the OSCE stations in Canada because our fellows in Calgary were not exposed to AEG, so they had no idea how to answer that AEG station, so they had to cancel. So from nothing, I had to fight giants. You had centers that they are very, very big, and they have already did years of advance in neonatal neurocritical care. How would I stand shoulder to shoulder to them? And that's where this book gave one of really interesting advice, was saying the story of David and Goliath. If David was to fight Goliath with sword, he would have lost in the blink of eye. But he chose a tool that Goliath is not used to it, and he's very good at it. So each one of us and each center has strengths that other centers don't have. If we build on those strengths and we expand on it, we will be able to stand shoulder to shoulder with giants in very short time period. So that will be my point.
Okay, thank you so much, Dr. Khorshid. Now, Dr. Saif is raising his hand. Dr. Saif is here.
Assalamu alaikum wa
rahmatullah.
Thank you, Abdullah, for giving me the chance to talk. And I would like to thank Dr. Khorshid Mohammad to spread the knowledge to help our tiny babies, that we're trying our best day and night to keep them alive. But again, quality of care is more important than just a live baby. I was honored to see Dr. Khorshid Mohammad first time in my life in Tampa, Florida, a few months ago. I was really happy to see him. I was thrilled to see him. He's the leading in neonatal neurocritical program in Canada. And I'm inviting him in front of all of you guys to come to Saudi Arabia again and trying to implement this program in the kingdom. Hopefully we'll help our babies. Inshallah, we'll convince him to come to us. We will be very happy to have him. We'll be very happy to be with him and learn from his experience and also inspire our fellows. Actually, when I saw him there, I asked him to take care of our fellows in Jeddah because he's coming to hot topics. And actually he did his best, and he actually helped them all and enrolled them in the program. And thank you very much for that, Khorshid. This is my talk about as introduction, but I have also our experience in National Guard, Riyadh. We have a very bad time when we have severe IVH. Our severe IVH incidence is high. It reached 9 to 10%. Then we try to do something. We heard about the neuroprotection. This is back in 2015, 2016. So we try to implement, as you mentioned, it's very hard to convince people to implement a program, new program. It's need a leadership. It's need someone follow all the guidelines that you implement and audit what you are trying to achieve. But unfortunately, we did not too much. However, we review the issue of IVH and we try to implement one of those, and we found it is very useful and helpful. We change our practice in regard to intubating tiny babies, because we are in a tertiary hospital, we are in an academic center, we have residents, we have fellows. So we make a guidelines, no resident or junior fellow will try to intubate tiny babies less than 28 weeks, unless they are already past the privilege period after 5 successful intubation under close supervision. Actually, we found the incidence of IVH decreased significantly. In addition to that, we have also in-house consultant calls 24/7. We started in 2016. So the incidence went down from 9.4 to 4.5% in 2017 and 18. And still till today, 2020, it's 4.5 or 5.4. I know it still is not zero. We're trying to achieve zero, but I think we have a lot of way to go. But I'm just trying to give our experience about minimizing the trial of intubation for tiny babies, especially in L&D. It may decrease the risk of IVH. I'm not sure if this has been explored or part of the bundle or not. And thank you very much, Dr. Khorshid Mohammad.
Thanks, Dr. Saif. It will be an honor to work with your team to implement this in Saudi. And in fact, Saudi was the reason why I chose NICU. I always wanted to do PICU, not NICU. And it was only when I worked in National Guard in Al-Hassa where I changed my passion, and was due to one of the consultants there who was a graduate from Calgary, Dr. Al-Abdi, who made the connection, and I ended up in Calgary, and the rest of history. So I owe Saudi a lot. I owe the Saudi my passion to NICU. For your question, it's absolutely crucial question. It's all in the variability, because if you have multiple intubation attempts in these babies, and it happens in all centers, we all have seen it. If these babies are already prone to ischemia, and now you are putting on top of that an incidence of bradycardia and hypoxia, then the brain autoregulation is already compromised. The risk of IVH go to the roofs by this multiple attempts. And the way we approach this here is because we have observed that variability, and it was so difficult to standardize the way we are intubating, extubating, and managing these babies. We said, just until we put our ducks together, all babies less than 28 weeks will be intubated until we will stay intubated for 72 hours. We know this is not the best, but the payoff by having variability in intubation and extubation is too much. It's okay, we'll have them. So, and then once we establish consistency in practice, then we start dropping gestational age by 1 week systematically. We went to 27 weeks, then 26 weeks, and now only 23 and 24 weeks, they get intubated by default, and they stay intubated for the 72 hours. That is because in our cohort, when we looked at them, most of them, they got intubated anyway in the first 72 hours. We said, instead of waiting too long to put that tube back in, we will be proactive and put the tube early on. And now we have, similar to your approach, is babies below 26 weeker and below, only senior people, only experts are the one who intubate these babies for the same reason that you have mentioned. So please publish. Your numbers are great, like 4.5 and 5.5 of severe brain injury in extreme premature baby is fantastic. The more we publish, the more we make the case. When I was in Sao Paulo last week, there was another city, they showed similar, they were able to decrease the incidence by 50%. So again, I plead to them to publish their papers, because we are adding to the literature. Thank you so much.
It is published, Prof. Khorshid, in Child Nervous System in 2020.
I will look it up and I will add it to my slides.
Thank you so much. Thank you.
Thank you. Thank you. Now, Dr. Ali Al-Mudir. We have Dr. Ali. We cannot hear you.
You hear me, Abdullah?
Yes.
Abdullah?
Yes. Go ahead.
Thank you very much, Abdullah, for this opportunity. And thanks to Prof. Khorshid. It's really very nice and amazing lecture. I listened to this talk for the second time. The first time was in Taif, and it's really very nice, very well approach. My probably question for the last maybe 2 or 3 slides you present, very nice, and like for that's baby, small tiny baby who's having grade 4. So my question, Prof. Khorshid, now what's your approach for the grade 4 bilateral IVH in your center? it's very nice to see that small baby to be practiced in ICU. But in reality, this is not always the best scenario to see those baby either if they make it to survive, or how their life in the future and quality of life. I know you have very nice system maybe for as high risk follow-up, but keeping that in the mind that we have a lot of challenges in high risk follow-up clinics, a lot of challenges with a good rehab center in the future. So how we can approach those baby or tiny baby with IVH grade 4. Thank you very much.
Thanks, Dr. Ali. It's nice to see you again. I hope we'll meet again in person. Two folds. This is extremely important question. One is how we manage these babies, approach the family with bilateral grade 4 IVH or unilateral grade 4 IVH for that matter. I think personalizing our approach is the way to go, and looking at what is the family's goal. And I will mention one paper here. It's published on PubMed. The title is provocative. It's called Pepperoni, Pizza, and Sex. And the story of this is there was a trisomy 21 child, and the physician, like you and I, were counseling the families about the expected outcome of trisomy 21. They will go over the learning disabilities, challenges, hypotonia, cardiac problem, etc. And then the family will interrupt him and he say, will my son be able to have sex? And then the physician will be taken back and say, probably yes. And then we'll carry on with our usual outcome, going systematically, system by system. And then the family will interrupt him again and say, will my baby be able to put pepperoni on the pizza? Because they had a pizza shop and they wanted him to put pepperoni on the pizza. And the physician said, probably yes. So the point here I wanted to make is families are different. Some families, they have a good structure. It's an IVF baby. They have tried for 20 years, and they are willing to work with their son or daughter, and they're willing to get anything, face all those challenges. On the other hand, there is a family are clear from the beginning, if there's any chance of cerebral palsy, I don't want to have my child going through this painful experience for my child, not for myself. So tailoring it to the family, the way to go, and that's why when I showed the images, it's important to look at the images, to show the family the images, because the reports, they will look the same. But when you look at that tiny grade 4 IVH versus big grade 4 IVH, the approach of the family also will change when they see that, when you explain that to them. The second fold I wanted to mention, yes, there is a better system for the follow-up and rehab and stuff. And I know you are working on establishing something in that regard, and also the database that you are working on. However, there are lots of things missing here that you still have over there. And that's the family structure, lots of interventions that we are trying to do it through the system. You already have it integrated in your day-to-day life, and you can use it. I'm not promoting any the TV shows or anything, but there is one on Netflix called On the Way to School. It's describing the journey of a few kids to school in different countries. And one of them is a kid with cerebral palsy going to school in India. And while I was watching that, I was watching every intervention and rehab that we pay money for here in Canada. It was integrated into their day-to-day life. His mom was doing the massage and physiotherapy, putting some oil on his body. He was going to a regular school, not a handicap or disabled school. The kids there were happy and playing and stimulating him, getting him through the mud. All those neuroprotective and neuroplasticity interventions was already there. We just didn't put a fancy name on them. So that's a long answer to your question, sorry.
Okay, thank you so much, Prof. Khorshid. We have a question here saying, can you use Doppler measurement of medial artery resistant index as a guide for presence of hypotension as a part of neuroprotection bundle?
Not for hypotension, I would say. For PDA, I use it as a marker for a hemodynamically significant PDA. And I use it for post-hemorrhagic ventricular dilatation. If you have a stealing phenomena, when you look at the Doppler through the anterior cerebral artery or middle cerebral artery, you will see that there will be either absence or reverse diastolic flow. Now, if you do the Doppler, if you have low resistive index, you can say that this brain is going through reperfusion phase, and you can justify to decrease those interventions that will increase the blood to the flow, like inotropes and normal saline boluses. In post-hemorrhagic ventricular dilatation, when we use it prior and after the reservoir tap, you could see before the reservoir tap, and that's the anterior cerebral artery, not the middle cerebral artery, because the middle is protected, it's in the base of the brain. It gets impacted by hydrocephalus way later than the anterior cerebral artery. But when you Doppler the anterior cerebral artery, before the tapping, you will see the absence diastolic flow. And right after the tapping, you can see the restoration of blood flow through the diastolic flow. And we show that to the parents because they become the strongest advocate for this vigorous tapping, repetitive tapping. There are sometimes resistance and pushback from staff and neurosurgeons, etc. But when the parents see in front of their eyes that right after the tapping, the blood perfusion was restored through the anterior cerebral artery. And that's probably one of the reasons where if you don't treat those post-hemorrhagic ventricular dilatations, some of them you get the worst cystic PVL because of that ongoing ischemia. So to answer your question, we don't use it to guide our hypotension treatment, more for PDA and post-hemorrhagic ventricular dilatation.
Okay, speaking about PDA, is there any preferable medication or first drug to use for PDA treatment on those IVH babies?
I don't think there is. I personally use endomethacin because of that prophylactic endo papers that came with Laura Mint that showed it does decrease the incidence of severe IVH. And I use it to treat PDA at the same time. So double treatment, double purpose for one treatment. And I use it when at the 24 hours when the PDA is still bidirectional, but mostly left to right. I must say, even among our group, there are lots of physicians and hemodynamic specialists. They are hesitant with this approach for good reasons. And sometimes even with the PDA, when there's completely left to right and there is a reverse diastolic flow, even with the baby, if the baby have AKI, I make the point to treat it even with endomethacin because the AKI for these babies is due to hypoperfusion. It's not due to actual renal failure. And sure enough, when you restore the flow to the kidney, the urine output improve and the creatinine start to come down despite using the endomethacin. There is good case for paracetamol. There is good case for ibuprofen. There is good case for not treating the PDA. I just think PDA is such an important factor that you need to put it in the complex picture of the IVH prevention and treat it at the right time. Because if you leave it too late, it becomes the risk factor. If you do it too early, you're probably getting rid of protective factor. Because if your PDA is bidirectional, it's probably restoring some blood to the brain.
Thank you so much, Dr. Khorshid. So regarding those baby with clinical hypotensive, so is there any preferable inotropes to use, dopamine, adrenaline, or norepinephrine?
I think there when your echo become important, and that echo, that type of echo doesn't require a full fellowship in hemodynamic management because all you are looking for is whether the heart is full or empty, is heart is contracting well or not contracting well. So let's bring some scenarios, and based on those scenarios, we can decide which inotropes should we use. If we have a baby with empty heart, the ventricles are contracting well and kissing each other, then your treatment obviously will be normal saline to fill that heart, because if the tank is empty, and we all have seen those cases where without echo, we give inotropes and we just add one after another, and yet the baby is becoming more hypotensive. When you put the echo on, you see the heart is just fluttering on an empty tank, and was only when you give normal saline and back off on inotropes where blood pressure improves. And those babies might have placental abruption, might have another reason for volume loss. On the other hand, if you have low contractility, poor contractility, but the heart is good, the filling is good, then you want to start something that improves your contractility. So that will be something like dobutamine or epinephrine. And epinephrine, the only problem with that in unit is the chronotropic effect, because it can cause tachycardia, but it is a good drug for a combination of contractility and some peripheral vasodilatation. And on the other hand, if your problem is just PDA that driving down your diastolic pressure, then probably a low dose of dopamine might increase your diastolic pressure and improve your mean blood pressure while you're deciding how to treat that PDA. And I know there was a question in the quick Q&A about the dose of dopamine, renal dose versus vascular dose versus cardiac dose. I think people are moving away from those doses, and it's patient dependent. Some of them, they respond to low dose, and some of them, they respond to high dose. And finally, the question of hydrocortisone, because sometimes is if this baby is forced to send the cortisol level and think of hydrocortisone treatment. Now, the only caveat is if you treat these babies within the first 72 hours, your indomethacin is out of equation, because of the combination of both might increase the incidence of spontaneous bowel perforation significantly. If the problem you are dealing with PPHN, on the other hand, then good ventilation, INO, or opening the PDA with prostaglandin sometimes would be the way to go to offload the right ventricle until you get through and transition through the PPHN. So without cardiac echo, if the baby is clinically hemodynamic unstable, it's literally shooting in the dark.
Okay. Thank you so much, Dr. Khorshid. Here is a question regarding, is there any role of lipid reduction the first days of life for those extreme premature babies in preventing IVH?
Not IVH, I would say, because IVH, if you think about it, is really a hemodynamic vascular event. So you need one of those big interventions that will change the some of the vital signs, CO2 fluctuation, blood pressure fluctuation, PDA, where you have stealing phenomenon, or sepsis, where you have vasodilatation and hypotension, etc. But those have rules in the longer neuroprotection effects. And there are some papers now on early use of protein and how much is too much, and early use of lipids. And there are data there about the long-term neuroprotection, but not in the IVH. And magnesium sulfate is one of them. If you really look at it, is if anything, magnesium sulfate is causing vasodilatation, and it may increase the incidence of IVH. It doesn't, luckily, but it at the cellular level, it is a neuroprotective agent, and it might improve the long-term outcome, or the other type of brain injury, which is the white matter injury.
So ending our question with an ethical question of having bilateral grade IVH and DNR.
It is very reasonable. You have to approach the family and see what they want, and look at the images itself. Is it at the lower spectrum of grade 4 IVH, or it's really big, massive hemorrhagic infarct? And at the end of the day, we support what family wants, as long as we make sure they are informed of the risk factors. And there are lots of uncertainty, I would say, and uncertainty is not bad always, because uncertainty opens the door for opportunities. And prevent the label locked mind. When we label something, our mind become locked, and we attribute everything to that label. For example, if we say grade 4 can cause cerebral palsy, and then whenever, if my child is walking at 1 year or 14 months instead of my neighbors is walking at 9 months, I would say this is because of cerebral palsy. I can't do anything about it. And that thinking of saying, but I can't do anything about it, contribute in the outcome itself. For me, not knowing the outcome, as parent, you invest more and you push them to the maximum. And that's the key factor in improving the outcome of these babies with grade 4 or grade 3 with post-hemorrhagic ventricular dilatation. And if you think about it, if you have bad grade 3 IVH, the risk of bad outcomes is actually worse than grade 4, pure grade 4 IVH, because grade 4 IVH will leave, or what used to be grade 4 IVH, now we call it periventricular hemorrhagic infarct. It will leave a porencephalic cyst, and if the baby put in the right, loving, interactive, stimulating environment and has enough space, the brain can rewire and bypass the injury. Where in the grade 3 IVH, with post-hemorrhagic ventricular dilatation and shunt, the risk of infection and risk of the worst outcome is higher. And I remember I asked Barbara Schmitz in one of her talks in Kuwait, why do you think that there was no difference in the long-term outcome with the prophylactic indomethacin? And she said something that resonated with me. She said IVH is overrated. And she's right, because you get an adult patient with massive stroke, and if anybody asks you, say, yeah, they will be fine. Initially, they probably won't be talking, they will be in coma, but in a month or so, they will be functional. They will have a little bit of weakness in their hands, and maybe their talking will be a little bit weird, but they will be completely functional. And yet, in babies, we are much more pessimistic when it comes to this thing compared to adults, when it should be the other way around. So that's my 2 cents.
Well, thank you, Prof. Khorshid. Really, I would like to thank you and thank all the participants for sharing their thoughtful question and their active participation. And really a special thanks and warm for Prof. Khorshid Mohammad for sharing his invaluable insight with us today. And we hope that this session has been informative and useful to all. So thank you, Khorshid Mohammad, and have a great day.
Thanks, Dr. Abdullah. Thanks, everyone. I'll send my email. Dr. Abdullah has my email, so I know there were lots of questions and Q&A I couldn't answer, but I'll be happy to answer. Thank you.
Thank you so much. Thank you.